Okay, so today's topic is arches of foot. So this curve on the sole of the foot, these are known as the arches of foot. Next, so we'll discuss this under this following headings. Next, so these are the footprints. Footprints are formed due to presence of these arches in our foot. Okay. So what are the functions of these arches? Arches of the foot is distinctive features of human. Okay, and it helps in walking, running, jumping, and also helps in weight bearing in upright posture. Footprints are complete due to these arches and present these arches are present since birth, but in infants you can see it is represents as flat because of it. अच्छा এটা একটু কমিয়ে দাও না হ্যালো আরেকটু হ্যাঁ ঠিক Okay, so these arches are present since birth, because but in infant they are masked due to presence of high amount of fat. Okay, in the foot. If you do X-ray in an infant, you can see the presence of the arch. Okay. So the medial longitudinal arch, two longitudinal arches are present mainly. Medial longitudinal arch and lateral longitudinal arch, and one generally transverse arch. Okay. So the medial longitudinal arch, it gives a propulsive force during locomotion, during movement, and the lateral longitudinal arch, it functions as a support and weight transmission. Okay. So these are the main functions of these two longitudinal arches. Next. So why these arches are present? A segmented structure. Our foot is formed of so many small bones. Okay. So if a segmented structure can hold up weight only if it is built in the form of arches. Okay. So if we have to transmit the body weight through the foot. So these bones are placed, foot bones are placed in the form of arches because of carrying of this body weight, to carry the body weight properly. And so how this body weight is carried? Weight will be distributed on the heel behind, and the heads of the metatarsal bones in front. Okay. Skeleton of foot হয়ে গেছে তো তোদের ডিসেকশনে বোনসে অস্টিওলজি কমপ্লিট হয়ে গেছে তো Okay, so you know the bones of the foot. Okay, so the weight will be carried, distributed on the heel behind. Heel is formed by the calcaneum and the heads of the metatarsal bones in front, and the pressure will be minimized, and this arch form, it helps to minimize the pressure on the nerves and vessels in the sole of the foot, and it also helps in forward propulsive action will be easier during movement. Next. So these are the bones forming the foot. Tarsal bones are the calcaneum, cuboid, navicular, talus, three cuneiforms. Medial, intermediate, lateral cuneiforms. Okay. These are the metatarsal, first, second, third, fourth, and fifth. And these are the phalanges, two for the great toe and three each for the lateral four toes. Okay. 14 phalanges are present, proximal, middle and distal, and for the great toe only proximal and distal phalanx. Okay. So these bones will take part in the formation of arches. Next. Foot is divided into three parts mainly: forefoot, midfoot, and hindfoot. Okay. So what are the bones forming it? Next. So hindfoot is formed, this pink one is hindfoot, it is formed mainly by the talus and calcaneum. Midfoot is formed by navicular, cuboid, and three cuneiforms. This is forming midfoot. And forefoot, it is formed by the metatarsal and the phalanges. Okay, so these are the three divisions of the foot. Next. So weight of the body is spread among 3 points: posterior inferior tuberosity of the calcaneum or heel here, head of the first metatarsal here, and head of the fifth metatarsal. Okay, so these are the 3 main points where the weight transmission occurs. Next, so this is the tuberosity of the calcaneum. These are the sesamoid bones. 2 sesamoid bones are present near the head of the first metatarsal, and second metatarsal head is also included in this dot. And these are third, fourth, and fifth metatarsal heads. All these are weight bearing. Next. So if the body weight of a person is about 120 pounds, so right foot will carry 60 pounds, left foot will carry 60 pounds. Okay. First the body weight passes through the talus. Then it will divide into 2 parts. 30 pounds will be carried by the calcaneum and rest of the 30 pounds by the head of the 5 metatarsals. 6 bearing points are present. So 30 pound will be divided into 5 pound each. Okay. So what are the 6 bearing points? Head of the 4 metatarsals, lateral 4, and 2 sesamoid bones under the hallux. These are the, so 6 bearing points are present. So that's how the body weight is transmitted in each foot. Okay. Next. So how these arches of the foots are maintained? There are different factors which are maintaining these arches. Say first the shape of the stones. Shapes are such. This bone is known as the keystone. Okay. Lower part is narrow, upper part is wide. Okay. Here in the arches, talus plays as the keystone. Intersegmental ties or staples, the small part which are tying the adjacent bones. Okay, these are known as staples. Here are we are ligaments, long plantar ligaments, short plantar ligaments, plantar aponeurosis like this, or calcaneocuboid ligament like this. These ligaments will act as this intersegmental ties or staples. Now there are slits. Slits helps in keeping, pulls the arch from upward. Here this flexure hallucis is longer sternum. It is acting as a sling. And tie beams will pull the 2 ends together. Okay. For the transverse arch, this peroneus longer sternum is acting as a tie beam. Okay. So these are the factors. All these factors are present in all the 3 arches. 2 longitudinal arch and transverse arch. So we will discuss those things, which muscle is acting as which factors. Okay. Next. So these okay, so arches or foots are divided into 2 longitudinal arches and transverse arches. 2 longitudinal arches are medial longitudinal arch and lateral longitudinal arch, and transverse arches are 2 transverse arch mainly. Anterior complete part formed by the heads of the metatarsals and posterior incomplete part. Okay, half of the arch is present in the posterior incomplete arch, and if you put your two feet together, the arch will be complete. Okay. Next. So see longitudinal arch, medial and lateral. See this yellow colored bones, these forming the medial longitudinal arch. Which bones are present? Talus, calcaneum. Here is the navicular, 3 cuneiforms, and medial 3, first, second, and third metatarsal. These are forming the medial longitudinal arch. Lateral longitudinal arch, this blue marked one bones will form the lateral longitudinal arch. So there will be calcaneum, cuboid, and 2 metatarsals. Okay, these are forming the lateral longitudinal arch. And transverse arch, these are anterior transverse arch, posterior transverse arch. Next. Now we will discuss individual arch. Okay. So medial longitudinal arch, this is viewed from the medial aspect of the foot. So this arch is known as the medial longitudinal arch, it is higher and important than the lateral longitudinal arch. It is composed of calcaneum, here is the calcaneum, then talus, navicular, three cuneiforms and the three metatarsals. And the talar head, it is the keystone for the arch. We have discussed the bones are shaped like wedge-like shape. Upper part is wider and lower part is narrower. So talus is the keystone for the medial longitudinal arch. Next, so medial longitudinal arch is higher than the lateral arch formed by calcaneum. Talus is the keystone, navicular, three cuneiform and first three metatarsals. Next, now lateral longitudinal arch, it is lower than the medial arch. This is viewed from the lateral aspect. Okay, it is formed by calcaneum. Here you can see this is the calcaneum. Cuboid. Here cuboid is forming the keystone of the arch, and fourth and fifth metatarsal bones. These are forming the lateral longitudinal arch. You have to remember which bones are forming which arch. Okay. Next is the transverse arch. If you are mentioned describe the transverse arch, you have to mention it is mainly represents the posterior transverse arch, okay, which is half of the arch forming for each foot. So it is only half of an arch. See, this is forming the transverse arch. We have cut the foot, okay, in a coronal plane. It is formed by bases of the metatarsals. These are the bases of the metatarsal bones, cuboid and three cuneiforms. All these are forming the transverse arch of the foot. Okay. Next, so this is lateral longitudinal arch, medial longitudinal arch. Lateral is on the outer side, so outer arch, medial is inner arch. You have to see the bones which are forming the arches. Next, so these are the schematic lines. Here is the medial longitudinal arch, lateral longitudinal arch. This is anterior transverse arch formed by the heads of the metatarsals, and in this region will be the posterior transverse arch. Okay, posterior transverse arch is more important. Next, see, this is the posterior transverse arch, here is the anterior transverse arch. Okay. This is the outline of the transverse arch. Next, so these bones were forming the shaded area, forming the lateral arch, and these are forming the medial arch. You have known the bones. Next, here also you can see this medial arch is more curved than the lateral arch. That one is lateral arch and this is transverse arch. Okay, transverse arch has been shown. These are the bones forming the two arches. Next, now what are the factors maintaining the arches of the foot? These are due to the shape of the bones, strength of the ligaments and tone of the muscles. These factors are maintaining the arches of the foot. Next, bones and ligaments, they are static stabilizer. Okay, they does not change. And muscles and tendon, pool of these muscles and tendon can change according to the position of the foot. Okay, so they are known as dynamic stabilizer. Okay, so these are the bones and green one is the ligament. And there are muscles. This yellow ones are representing the muscles. Okay, and muscles and tendons. Different tendons are also present. Next, so what is the method of maintaining the arch? Due to the shape of the stones, one will be keystone and other stones are also placed like the arch. Here, for this bridge, this stone is the keystone, and for this transverse arch, this bone is forming the intermediate cuneiform is forming the keystone for the transverse arch. Okay. For the medial longitudinal arch, talus is forming the keystone, and for the lateral longitudinal arch, cuboid is forming the keystone. Okay, so these three keystones has been shown. Now intersegmental ties of staples, you have seen The long plantar ligament, short plantar ligament are the ligaments are forming intersegmental ties. Then tie beams, the tendons of the muscles are forming the tie beams, and slings or suspension beams. These are also formed by the different tendons of the muscles. So for individual arch, which structure is acting as which parts, we will discuss. Next, so this is suspension, suspension. This is the suspending the arch from the above. Here, peroneus longus for the lateral longitudinal arch, acting as a suspension bridge. Next, so first we will discuss the according to shape of the bones. Bones are wedge shaped with thin edge lying inferiorly and thicker edge above, and this applies particularly to the bone occupying the center of the arch, and that is known as the keystone. Here talus is forming the keystone. Next, so bones are wedge shaped with thin edge lying inferiorly, and this applies to the bone occupying the center, keystone bone. Okay, next. And inferior edges of the bones are tied together like the staples or intersegmental ties here. These are the intersegmental ties for this bridge. Okay, and for the arches, these ligaments, short plantar ligament, long plantar ligament, calcaneonavicular ligament, all these ligaments are acting as staples. Okay. Next, now the inferior edges of the bones are tied together by these ligaments. For the medial longitudinal arch, plantar calcaneonavicular ligament and tibialis posterior. And for the lateral longitudinal arch, long and short plantar ligament. And for the transverse arch, deep transverse ligaments, transverse head of adductor hallucis and dorsal interossei. All these structures are acting as the staples. Next, see, these are the ligaments. Here is the long plantar ligament. Here is plantar calcaneonavicular ligament, medial cuneonavicular ligament. These are the articular capsule of this joint, and this is deltoid ligament. Okay, and these are the medial talocalcaneal, posterior talocalcaneal. These are connecting the each bones like the staples. Next, okay, this is the fourth layers of muscles of the soul. Okay, this tendon, this will act as a sling, peroneus longer tendon. This crosses from lateral to medial side, insert into the base of the first metatarsal and the medial cuneiform. And this is tibialis posterior tendon insertion. And these are the palmar interossei and dorsal interossei. Okay. Next, so tie beams, see, this is the tie beam for this bridge. It connecting the two edge of the bridge. So it is tying the ends of the arch together like a tie beam. So in this case, tendon of the flexor hallucis longus is acting as the tie beam. Next, tying the ends of the arch together, this tie beam. Okay, tendon of flexor hallucis longus. Next, so what are the structures forming the tie beams for these three arches? For the medial longitudinal arch, plantar aponeurosis, medial part of the flexor digitorum longus and brevis, flexor hallucis longus, flexor hallucis brevis, and abductor hallucis. You have to know these muscles, its origin, insertion, attachment of these ligaments. Then only you will be understand which structures is acting as tie beams or staples or acting as a sling. You will understand then. Okay. Yeah, when the sole dissection will be done, all these structures, some of these structures you will show. 4 layers of sole muscles are present, and the ligaments you will see them. Okay. So lateral longitudinal arch, for the lateral longitudinal arch, tie beams are plantar aponeurosis, lateral part of the flexor digitorum longus and brevis, digiti minimi, and flexor digiti minimi. And for the transverse arch, peroneus longus is acting as the tie beams. Next, see here, this is after removing the skin of the sole. This triangular part, this part is known as the plantar aponeurosis. Okay, and these are the deep transverse ligament. Okay, plantar aponeurosis you have seen in the dissection of hand, palmar aponeurosis. Like that, corresponding structure in the foot is the plantar aponeurosis. Okay. Next, these are the insertion of different muscles. You see, here is the flexor digiti minimi brevis. This is the tendon of peroneus longus, also known as fibularis longus. Okay, this is hooking around this lateral border and inserting into the base of the first metatarsal and medial cuneiform. This is the flexor hallucis brevis inserted into the base of the proximal phalanx of the great toe. This is tendon of the tibialis posterior insertion, and this is flexor hallucis longus. Here is the flexor hallucis longus, and these muscles is adductor hallucis. It has two heads. One is oblique head and one is transverse head. Okay, and these are transverse ligaments. These ligaments. Next, this is first layer of muscles of the sole. Abductor hallucis towards the hallux, abductor digiti minimi towards the little toe, and in the middle flexor digitorum brevis. It has four tendons for the lateral foot toes. Next, now the suspending the arch from the above like a sling. See, this is the sling for this bridge, and for the lateral arch, peroneus longus is forming the sling. Next, so what are the structures forming the sling for the three arches? For the medial longitudinal arch, tibialis anterior, tibialis posterior, medial ligament of the ankle joint. These are forming the sling. And lateral, for the lateral longitudinal arch, peroneus longus and peroneus brevis is forming the sling. And for the transverse arch, peroneus longus is forming the sling. Okay. Next, see here, peroneus muscle has been shown. Okay. This is tibialis anterior. For the medial arch, it is forming a sling, and for the lateral arch, these structures are forming the sling. Okay. You can remember like Tom, Dick, and Harry. Tom is tibialis posterior, tendon of tibialis posterior. D for flexor digitorum longus, and Harry H is for flexor hallucis longus. Okay, these three are together forming the sling for the lateral arch. Okay, understood? Next, the position of peroneus longus and brevis has been shown. Lateral view, this is peroneus longus, and on under cover of it in the lower part, this is the peroneus brevis, and the tendons are going like this. Okay, acting as a sling for the lateral arch. Next, see, this is tendon of peroneus brevis, tendon of peroneus longus. Okay, and acting as a sling for lateral arch. And here this is section of the peroneus longus, and these are the ligaments, staples. These are acting as staples. Short plantar ligament, long plantar ligament. Next, those things. Fourth layer, tendon of peroneus longus, tibialis posterior. These are the palmar interosseous, plantar interosseous. So now we will go to the clinical aspect. So there are structures for maintaining the arches. You have to remember how the arches are maintained. Arches of foot comes as a long question. It can come as a long question. Okay. Or individual arch can be asked as a short note. Medial longitudinal arch or lateral longitudinal arch and transverse arch. Okay. So you have to remember how the arches are maintained. Factors maintaining the arch. That only comes as a question, long question. Okay. So you have to describe all these things: keystone, then staples, tie beams, slings, or what are the structures playing all these roles for individual arches. You have to remember. Okay, for arches of foot. First, you have to write down which bones are forming the arch. Then you write down the factors maintaining these arches. Okay. Now we will go to the clinical aspects. First is pes planus or flat foot. It is very common. Okay, in obese individual or in any disease condition, it generally occurs. It is a condition in which the medial longitudinal arch is depressed and the forefoot is everted and the head of the talus is pushed downward and medially and the causes are both congenital or acquired cause. Next, see, this is normal foot. Normal arch is present. This is flat foot. Arch is obliterated. See, normal arch is present. Here, foot is like totally flat. Arch is absent. Almost absent. Okay. And this is claw foot. Here, high arch foot. Okay. Arch is increased in claw foot. See, arch is more than the normal claw foot. Next. So, pes planus, that is the flat foot, normal foot with the arch, where the arch is flattened. Okay, this is a picture of flat foot. Okay. Next, this is pes cavus or high arch foot. See, this is normal arch, here arch is increased. This is the picture of pes cavus. Okay, concavity is also increased. Okay, on the under surface of the foot. Normal foot position, cavus foot or high arch foot. Okay, this will be a footprint. For normal footprint is like this, and for the pes cavus or high arch footprint will be like this. This part is not present in the footprint. Okay. Next, for the flat footprint will be like this. This part is also added with the normal foot. So from the footprint you can determine the condition. Okay, flat foot or high arch foot, normal. Next. So in flat foot, what occurs? This is the normal foot position, but in flat foot, weight is on the inside edge of the sole. Okay, excessive pronation occurs in this flat foot. Next is the claw foot. Here, this is the picture of claw. This is normal foot. This is claw foot. Okay, forefoot is inverted. Next, so claw foot has this four component. Cavus. See, this is cavus means high arch. Foot will be high arch. Adductors. It will be pushed medially. Adducted. Varus. That means forefoot is inverted. Varus and equinus. Equinus means horse-like. Okay. This cavus is almost representing the equinus. So foot will be look like this. Okay. So this is claw foot. Okay, next. So different type of claw foots are also known as talipes. This is talipes cavus. Only cavus component is present. Talipes equinus. Heel is not touching. Okay, only toes are touching. Talipes calcaneus. Calcaneum is touching. Toes are not touching. Talipes valgus. Foot is everted. Sole of the foot is directed outward. You know eversion and inversion? Yes or no? Yes, okay. So here the foot is everted. Then talipes equinovarus. Equinus component and varus, that means inversion. Both are present. It is calcaneo valgus. Calcaneus and valgus, both are present. This is talipes varus. That means foot is inverted. Talipes cavovarus. Okay, cavus and varus, both components are present. Here is equinovarus, equinus, that is heel will be up, and varus component is present. This is varus inversion, and talipes calcaneovarus, calcaneum, talipes calcaneum, and cavus. It is high arch of the foot is present. So these are the different types of club foot or talipes. Next, this is one important disease, congenital talipes equinovarus. Okay, this disease you have to learn in your ortho and pediatrics. Okay, very important. It comes as a short note, not in your first year in your final year you have to learn all the components and how will you treat it. Okay, so there will be hind foot or ankle will be like this, or inversion at the subtalar joint complex will occur. Plantar flexion of the forefoot on the hind foot. That means cavus, varus, equinus. Okay, heel will be up and forefoot on the midfoot. There will be adduction. Forefoot will be adducted towards the midfoot. So these are the four components of the congenital talipes equinovarus, CTEV. Okay, this short form is very commonly used. Important disease, clinical condition of the foot. Okay. Okay, that's all. Any queries? This comes as a short note, this clinical aspects, pes planus or pes cavus or the CTV or club foot, these four things generally comes as a short note. Or if the arches of foot comes as a long question, part of the long question can be given from this clinical aspect. What is club foot, what is pes cavus or like this, okay? Okay, that's all. Any queries? So, three arcs you have to learn properly. Medial longitudinal arch, lateral longitudinal arch and transverse arch. Okay. Transverse arch means if you have to mention only transverse arch, it represents the posterior transverse arch. Okay. Which is half for each foot, and if you place the two foots together, then the transverse arch will be complete. Okay. And another transverse arch is formed by the heads of the metatarsals, that is a complete arch for each foot. Okay, anterior transverse arch. If they mention anterior transverse arch, only then you tell that one. Okay. Okay. Any queries? So we have to remember all the structures, maintaining the factors, maintaining the arches. That only comes as long question. Okay. Yes. Plantar ligament? No. Plantar inflammation of plantar aponeurosis. Aponeurosis inflammation is known as plantar fasciitis. That is the fascia, plantar fascia. Plantar aponeurosis, other name is plantar fascia. Okay. Plantar aponeurosis was the triangular one. After removal of the skin, that is part of the deep fascia of the foot. Okay. Like the palmar aponeurosis, that was triangular, 4 sleeves for the 4 fingers. Plantar aponeurosis is also like this, 5 sleeves for 5 fingers. Okay. Okay. Okay, that's all. No other queries? Okay, thank you.
You already know that protein is a major source for body functioning. It is already a building block material, and several definitions and several functions are given in the books. You already know in detail that what is the protein is doing in our body. Okay? And when you see the definition of protein, you know that protein is a sequence of amino acid which are linked together by peptide bonds. Okay? But in the metabolism sections, there is two processes. The first one is catabolism, second one is anabolism. That means something is synthesis, then it is breakdown. Okay? So, what happens when you take the protein in your diet? Firstly, it becomes breakdown. The large macromolecules of proteins, large polypeptides, okay, large protein molecule become degraded, become breakdown by some proteolytic enzymes. You already studied in digestion and absorption process that the proteins molecule become breakdown by some proteolytic enzymes. Okay, by the enzyme activity, it is converted into smaller fragments, into smaller molecules. Okay, and after the absorption, it's become converted into a amino acid pool. What is amino acid pool? You already know that amino acid is what? You know amino acid what? It is a primary unit of protein. It is a primary unit of protein, and when you see the structure classification of amino acid, it is being classified at a 7 major classification on the basis of their presence of some special functional group, on the basis of presence of their some acidic properties, some basic properties, some polarity, and also on the basis of some metabolic fate. Okay? But in the metabolism section, we divide the protein metabolism on the basis of their structure classification. First, we studied the metabolism of simple amino acid. Then we studied metabolism of aromatic amino acid. Then we studied metabolism of some other amino acids. Okay? Before that, the major question is asking in the university exam. In the university exam, the major question is asking, write the storage functions of ammonia, transport of ammonia, and metabolic fate of ammonia. Metabolic fate of ammonia. This question is majorly asked in your university examinations, that formations, storage, transport, and toxicity. Formation, storage, transport, and toxicity of ammonia. But question is that how ammonia are come, how ammonia are formed. Understand what is ammonia? This is NH4, NH3. Huh? How it is come, how this developed, how it is formed? It is formed by majorly, ammonia is generally formed. So, we understand all these things by some of the important reactions. Okay. So, today topic of discussion is what? Today topic of discussion is formation of ammonia, transportage and storage of ammonia, after then toxification of ammonia, and lastly metabolic fate. Okay. So, what is the metabolic fate of ammonia? What is? It is the formation of urea. Formation of urea. How urea is formed? By the urea cycle. Okay. By Hans-Krebs cycle. Okay. By this formation of urea, it becomes excreted out through the urine. It is excreted out in the urine. Understand? So, it is same like that. Question I was asking, what is the waste product of protein? Urea. What is the waste product of purines and pyrimidine nucleotides metabolism? Uric acid. Understand? And some of the amino acid are participate for the formation of glucose molecules, and we call this amino acid as glucogenic amino acid. What we call? Glucogenic amino acid. So, you clearly make a concept in your mind that if you take protein in your diet, firstly it is breakdown and makes the smaller fragment, then it is converted into a split into in what? In amino acid. And these amino acids further going for central dogma process for the protein synthesis, first thing, and second thing, it is helpful in the formation of further metabolism for the formation of ammonia. For the formation of ammonia. Okay. So, this is the first being first and important step for starting the protein metabolism. Okay. formation, storage, formation and storage. So when we studied, जब हमने अमाइनो एसिड पढ़ा था, आई थिंक यू ऑलरेडी अंडरस्टैंड द हिंदी लैंग्वेज बेसिकली है. जब हमने अमाइनो एसिड पढ़ा था तो उस समय हमने एक वी अंडरस्टैंड द प्रॉपर्टीज ऑफ अमाइनो एसिड कॉल्ड ट्रांसएमिनेशन एंड डीएमिनेशन रिएक्शंस. वी अंडरस्टैंड द ट्रांसएमिनेशन एंड डीएमिनेशन रिएक्शन, द फॉर्मेशन एंड स्टोरेज. सो इम्पोर्टेंट formation of ammonia is transamination reaction, transamination reaction and deamination. This is being the first step for the formation of ammonia. Okay, it is basically a principal source of ammonia. What? Principal source of ammonia. And primitive purine and pyrimidine metabolism. Okay. So this the major concerns have come. Third one, biogenic amino acids. Some biogenic amino acid we call biogenic amines are the sources of ammonia. Biogenic amines. Biogenic amines, and the last one is some intestinal bacteria. Intestinal bacteria. Some intestinal bacteria which produces ammonia, and we call it is urea splitting enzymes. Urea splitting. Urea splitting. So these being the first step, first sources of ammonia. Question is comes in the university exam like that. Write the sources and formation. Sources and formation. This forms the ammonia. Transamination reactions. Okay. Transamination reaction. After then purines and pyrimidine metabolism. Biogenic amines and some intestinal bacteria forms what? Ammonia. Okay. Now we understand the basic concept. You understand because I think you studied the transamination reaction, deamination reaction. We revise that. If anyone can define what is transamination reaction? Yes, anybody else from the class? Yes. Very good. Transamination reaction is what? It is a intracellular process. You just understand intracellular process. There are sub transaminases are present which doing the ping pong mechanism. The reactions. The basically concept of this reaction is what? Ping pong mechanism. Have you understand ping pong mechanism? Pick up from one side and drop from other side. This is called ping pong mechanism. So here is what? Here is transfer of amines group. Transfer of amines group from one amino acid to another amino acid. From one amino acid to another amino acid. So what is the definition of this? Transamination reaction is the reactions in which alpha amino group is enzymatically transferred. Why we call enzymatically transfer? Because in these reactions there is vitamin 6 is required. Vitamin 6 is required. Vitamin 6 is required. Vitamin 6 is required. Yes, madam, you one, last one, please tell me the name of chemical name of vitamin B6. If you are not sincere in the class, then how will you gain it? Because your vitamins topic is already completed in the lecture sections. If anybody faculty taught, you will be serious. This is pyridoxal phosphate, PLP, we call pyridoxal phosphate, enzymatically transferred from an amino acid to alpha keto acid. It is a reversible reactions, okay, and yield a new acid and another keto acid. And these reaction is basically performed by transaminases. Transaminases means what? Transaminase simply you called it is, sir, it is molecules which proceed the transamination reaction. This is called transamination. Transaminases, which is one we call transaminases. Which called transaminases. There is transfer of amino group from one amino acid to another amino acid. Okay? I will give the example, you understand. The first one is which forming glutamate plus oxaloacetate. So there is transfer of amine group, okay, and this is called glutamate. Here glutamate contains amines groups, glutamine. Okay, so there are two transaminases basically present. Mainly two transaminases basically present which perform this transamination reaction. The first one is SGOT and second one is SGPT. SGOT and SGPT. Very important intercellular enzyme, intrahepatic enzymes. In clinical enzymology, I think you studied about this SGOT and SGPT. This is the most prominent enzyme which we diagnose in liver disease, in viral hepatitis, acute pancreatitis, liver cirrhosis, fatty liver, CLD, chronic liver disease, acute liver disease. We measure this. And the normal level of this, both the enzymes are 5 to 40. International unit per ml. International unit per ml. The major function of this what? SGOT, SGPT is what? Transfer of ammonia. Transfer of ammonia. So this is the basic enzyme of this reaction. OT. Okay, this is serum glutamate oxalotransaminases. So for making the concept, if the question is asking, write about transamination reaction. Okay, so how will you remember? How will you learn? कैसे याद रहेगा आपको? आपको SGOT याद है, आप रिएक्शन लिख दोगे. कैसे? Just simply you write from G, it is glutamate, okay, O oxaloacetate, okay, and this is aspartate. Because the another name of this reaction is and ALT. aspartate transaminases, alanine transaminases. Understand? If you remember both the names of enzymes, you easily understand what is transaminases. Okay, and these enzyme basically serum glutamate oxalotransferase is depend on ELP, vitamin B6 for these reactions. Pyridoxal phosphate. Pyridoxal phosphate is important. Pyridoxal phosphate. So you understand what is happening here? There is transfer of amine group from one amino acid to another amino acid. Okay. So this is called transamination reactions, and generally these reactions, second one reactions is in the cytosol. This reaction proceeds basically liver, and in muscles there is one reaction for transamination reaction, that is alanine plus alpha ketoglutarate, alanine plus alpha ketoglutarate forming glutamate plus pyruvate. This is SGPT dependent reactions. Okay, SGPT dependent reaction. The first one happened generally in the liver, basically in the liver cells, in hepatocytes. Okay, and second one is in muscles, because alanine is a storage form. It is stored in the muscles, and it is a glucogenic amino acid. Glucogenic amino acid is what? These alanine provide what? Pyruvate, and these pyruvate act as a substrate for process gluconeogenesis. You already know gluconeogenesis. So what we call this called alanine glucose cycle. Alanine glucose cycle. So this is another concept. You understand transamination reaction? Transamination reaction is just simply it is a reaction in which transfer of amine group from one amino acid to another amino acid to form new amino acid and new keto acid. Okay. So these both are the reactions. The first one, the second one, and the major raw ammonia. This is being the first step of protein metabolism. For this reaction, what is required? We require transaminases. A transaminases is what? SGOT and AST. SGPT and AST. If you remember both the names of these transaminases, you easily write the reactions. How will you write it? From SGOT, you will write glutamate and oxaloacetate. The another name is AST. You will write here AST, aspartate plus alpha ketoglutarate, which gives what? Which gives glutamate plus oxaloacetate. Okay. Same as in the second reactions, you will write it is alanine. Okay. Now, second reaction is deamination reaction. We call oxidation deamination, oxidative deamination. What we call deamination? Deamination, simply, if you listen the term deamination, there is removal of amines group, removal of ammonia. Okay, removal of ammonia. Removal of ammonia. Deamination, it is being two types. First one, oxidative deamination. And second one is non-oxidative deamination. Oxidative deamination. Non-oxidative deamination. Okay. So what is the definition of deamination? Very good. It is removal of ammonia. But its definition is what? Deamination reaction involve removal of alpha amino group and amino acid as free ammonia. As free ammonia. Removal of alpha amino group and amine group as free ammonia. It is a two process. The first one is oxidative deamination. That means there is oxidation occur. Where is oxidation occur? In the mitochondria. In the mitochondria. The site of oxidative deamination is what? Mitochondria. Okay? Mitochondria. And non-oxidative reactions is sub for another amino acid which not required, which enzyme basically? Which not required NADP and NADH. Understand? Which not required NADP and NADH. We understand with the example. You understand with the example all of this. The first one is oxidative deamination. There is one enzyme is required here, glutamate dehydrogenase. That is glutamate dehydrogenase. Very good. Okay. That is the example of oxidative deamination. Student, understand? Plus NADP and there is enzyme glutamate dehydrogenase. Glutamate dehydrogenase is an enzyme which is metallodependent, metalloenzyme. Tell me the name of metal which depend glutamate dehydrogenase. Question समझ में नहीं आया. The glutamate dehydrogenase is a metalloenzyme. You understand metalloenzyme? पढ़ा हो तब तो आएगा. पढ़ते ही नहीं हो. पढ़ते हो. Carbonic anhydrase is depend on what? हाँ आप समझ में आया. It is zinc dependent enzyme. Zinc. Okay. It is zinc dependent enzyme. Glutamate dehydrogenase is an enzyme, enzymatic process, and it form alpha ketoglutarate plus NH3. What it form? Alpha ketoglutarate plus NH3. Removal of ammonia from glutamate. So which is the storage form of ammonia? Glutamate. Okay. Which is a transported form of ammonia? Because ammonia is toxic. Ammonia is toxic for the body. And in the case of acute renal failure, in the case of CLD, liver disease, this ammonia is elevated in the body and the condition we referred as hyperammonemia. Hyperammonemia, it is elevated level of ammonia is occur in the body. So this is toxic and this cause several symptoms. We understand the symptom in the, we understand. So this is first removal of ammonia by oxidative deamination. Oxidative deamination. Removal. Now the non-oxidative deamination, there is no requirement of particular enzymes. It is serine, histidine, this serine dehydrogenase is enzymes which is further proceed by PLP and it forms glutamate. It forms removal of ammonia as pyruvate and ammonia NH3. Keto acid, alpha keto acid. Here is removal of pyruvate plus alpha keto acid plus NH3. So this is an example of non-oxidative deamination. It's mainly occur basically not in mitochondria. It is all happening. Now histidine, another example. Histidine, it forms uronic acid plus NH3. Uronic NH3. So this is formation of ammonia by two of the major steps, transamination reactions and oxidative deamination reaction and non-oxidative deamination reactions. Okay. And transamination and deamination is a property of amino acid. It is basic property of amino acid and it is a major important step for further reactions. Okay, oxidative deamination reactions. If the question is asking how the ammonia is stored, how the ammonia is transported, so you easily say it is stored in the form of glutamate and transported as a form of glutamine. Okay. Because this is storage glutamate plus NH3, it forms glutamine. Glutamine. Okay. Storage and transport form with the enzyme of glutamine synthase. With the enzymes of glutamine synthase, same as in the muscles. Synthase. Okay, this is the storage form of ammonia and transport is form of ammonia. Okay. So major of the ammonia is majorly present in also in the brain. Okay. If the elevated level of ammonia is happen, what happen in the body? If intoxication of ammonia occur, what happens? Fourth bench, last student. You are not in the class. Tell me what is transamination reaction. Just stand up. No, you sit down. You stand up. Tell me what happens if there is intoxication of ammonia. Tell me fast. ज़्यादा टाइम नहीं है. यू आर नॉट इन द क्लास. अभी बोल रहा हूँ लास्ट टाइम पे, सीरियस हो जाओ. जितने लोगों सभी से बोल रहा हूँ, ऑल ऑफ यू सीरियस. यू ऑलरेडी नो द रिजल्ट ऑफ योर सीनियर्स. I don't want to produce a fear in your mind, but you just alert. Be alert. Be in the class. This is a major portion which comes in university examinations. Okay. Now functions. Functions. The major functions of ammonia is used for the synthesis of pyrimidine and purines. ठीक है, used for the synthesis of pyrimidine and purines, amino sugars, glycosamine, glycosidum, acid base balance and non-essential amino acid. Non-essential amino acid. Because in purine and pyrimidine there is requirement of N base, nitrogen base, and this nitrogen base is basically provided by ammonia. Understand? So it is important for pyridine and pyrimidine. Second one, for maintain acid base balance. For maintain what? Acidic in nature. Okay. Ammonia is acidic in nature. Acidic in nature. Now, third one. For amino sugars. Anybody from class? Tell me the name of example of amino sugar. Glycosaminoglycans. Glycosaminoglycans. Okay. One for biogenic amines. So this is major functions of this ammonia. Ammonia is, if ammonia is elevated, it is toxic in nature, intoxication in nature. This produces several symptoms. This produces neurological symptoms because ammonia generally present in the form of glutamine in the brain. If it is elevated, this cause some neurological disorders. Okay. So question, now disposal of ammonia, you understand? Disposal means how it is degraded. Converted into urea and we excrete out urea in the urine. That's why we call it is uricotelic. All the mammals, we all are uricotelic in nature because we excrete urea in the urine. So what is the major, how this urea is formed? By, very good, by urea cycle. So what is important? We important here, we studied about urea cycle also. तो हमें यूरिया साइकिल भी पढ़ना पड़ेगा. क्या पढ़ना पड़ेगा? यूरिया साइकिल भी पढ़ना पड़ेगा. समझ में आया? फंक्शंस क्या थे? डिस्पोज किस फॉर्म में हो रहा है? डिस्पोज, इट इज डिस्पोज इन द फॉर्म ऑफ यूरिया. What happen if it is not disposed? What happen if the ammonia level is increases? It is toxic. The question comes in your university exam about 4 mark in justification. The question pattern is like justify it. उसमें एक क्वेश्चन आता है why urea is toxic for brain. Why urea is toxic for brain. Question is comes why urea is toxic for brain. Please, anybody can tell the answer. Hmm? Maturation. Maturation means what? It is happening in the age of 45 years. What is the growth of the brain? Tell me what is. Sit down. First, you understand what I tell you. I will tell you what happen if there is more ammonia is there, if there is hyperammonia is there. Okay, what happened? So you understand, make the concept with this reaction also, that how ammonia is concept, you easily give the answer. You easily give the answer. That is, alpha ketoglutarate is glutamate, and these glutamate, when react with NH3, it form glutamine. Okay, so this is the storage and transport form of ammonia. So I ask, what happen if the ammonia is raised? What happen if the ammonia is raised? Okay. Very good. It is the first answer, that alpha ketoglutarate is not forming well, and it is a major component of TCA cycle. Cycle, what is the function of TCA cycle? Productions of ATP, and ATP is not produced. ATP is not produced. First concept. It is being the first concept. Second one, second reason, because glutamine is basically a neurotransmitter. It signals in neuron cells. Okay, it signalizes the neuron cells, and by the property of this gamma aminobutyric acid. Gamma aminobutyric acid. If it is formed in excess amount, it causes disoriented the function of GABA, and due to this, there is neurological symptoms arises. Patient become feel first one blurred vision, blurred vision. Second one, slurred speech. Is not able to speech. It is not able to speak clearly. Third one is tremor. Tremor, you know? Tremor, you know? You easily understand, there is no coordination of both the hands for some times. How will you see the patient? If such condition of physician observe, they raise their hand for some times, and if there is neurological symptoms is comes, they are not able to straight their hands. They just lose their hands, lose their coordination. This is called tremors. Okay? And the fourth one is ataxia. And fifth one is Leschly coma. And if there is more intoxication, it leads to death. Okay? So, this gamma aminobutyric acid is disoriented. And second one, from the GABA, there is a formation of serotonin. And these serotonin also alter the function of neuron cells. Okay? So question comes in the university exam, why urea is toxic for brain. You just write the first concept, because if there is excess amount of urea occur, it is present in the form of glutamine, and these glutamines not forming alpha ketoglutarate, not functioning alpha ketoglutarate, and alpha ketoglutarate is a major intermediate source of TCA cycle. Major intermediate source of TCA cycle, which inhibit the TCA cycle, and there is less productions of ATP. First thing. Second one, it leads to the formation of GABA, and if there is GABA is a basically neurological signaling performing components, and these leads disoriented also, and these also forming serotonin. So all these are the basic example of toxification process of the brain by ammonia. Now we understand disposal of ammonia. Okay. Very easy way you understand all the things. Okay. Now we understand disposal of ammonia by cycle, by urea cycle. Okay. First we also call urea cycle as ornithine cycle, and second one we also call क्या Hans Krebs cycle. Hans Krebs cycle, ornithine cycle and Hans Krebs cycle. This is a bicycle, basically we call it, is act as a bicycle. Bicycle means two cycles run in the body in the same way. Which one two cycle? TCA cycle and urea cycle. We make also the connectivity here. You should understand. ये बाद में ले लेना. After the class, don't disturb the class. Okay. So first one, it is the first thing is come here. What is the site of urea cycle? Site of urea cycle. It is partially mitochondrial, partially cytosolic. And partially cytosolic. Okay. What is where? How much enzymes is used here? 5 enzymes is used here. Second one, there is 5 disorders related with urea cycle and one major HH syndrome. HH syndrome, one major HH syndrome. And from these 5 enzymes, there is one important enzyme is also participate. We call this enzyme is NAG, N-acetyl glutamate. Very important enzyme. Okay. And acetyl enzymes is required. Okay. Now we understand the reactions. First, now we understand make the cycle of this urea cycle, and we easily understand it. Okay. So this is firstly what we call ornithine cycle or urea cycle, and it is majorly present in the cytosol and mitochondria in the hepatocyte, because in liver there is presence of arginase enzymes, and arginase enzyme is a very prominent enzyme for removal of ammonia from arginine. Okay, we understand from this cycle. Okay. So now you understand all the cycle from one by one, step by step. Easily understand one by one with main steps. Now the first step is CO2 plus NH3 forming here carbamyl we also write this CPS, carbamyl phosphate. Okay. Carbamyl phosphate with the help of enzymes CPS1. This is CPS1. CPS1 is an enzyme present in the mitochondria. You clearly make the concept. CPS second enzyme present in liver cells, in the cytosol of liver cells. Okay. And these CPS1 enzymes molecules CO2 and NH3 and CPS second are helpful for the formation of purine and pyrimidine. This is the basic concept both of these enzymes. Okay. And there is and acetyl glutamate. Okay. Here student, please tell what is allosteric enzyme? Yes. Allosteric enzyme is what? It is when there is requirement of coenzyme, there is activator which attach with the active site, they can activate the enzyme. If it is inhibitor is attached with that, it inhibit the activity of enzymes. Okay. So that's why it's allosterically regulation of this step. You understand that this step is majorly firstly happen in mitochondria. Okay. Now in the second step, the carbamyl phosphate is react with ornithine. Forming here citrulline with the enzyme OT, ornithine. This is the second enzyme. This is first enzyme. These two steps are proceed in the mitochondria because these enzymes are present in mitochondria. Okay. So these enzymes are present in mitochondria. So these steps are proceed in mitochondria. हम कैसे याद करेंगे, हम कैसे याद रखेंगे कि कौन सा स्टेप माइटोकॉन्ड्रिया में हो रहा है, कौन सा स्टेप लिवर में हो रहा है, कौन सा स्टेप साइटोसोल में हो रहा है. जो एंजाइम ए से शुरू होगा, those enzyme started with A, it is this process, this reaction happen in cytosol. Okay. So now in this step there is citrulline. Now after the formation of citrulline there is enzyme arginosuccinate synthase. Arginosuccinate synthase, which required 2 ATP using single ATP and inorganic phosphate, forming arginosuccinate. Okay. Understand? Those enzymes start with A, it is happen in the cytosol. Okay. Now in the next step, there is formation of arginine. arginine, okay, by the enzyme arginosuccinate lyase. Arginosuccinate lyase. You already know the class of these enzymes, because if you read the classification of enzyme, you easily understand. Okay, arginosuccinate lyase, there is a formation of arginine. Okay, arginine is forming, and by the enzymes of arginine, by the formation of arginine, there is formation of orthonin by the activity of arginase. And these arginase enzymes is majorly present in liver. Okay, so this happen in the liver. Urea cycle is majorly happen in the liver. If liver is not well developed, if there is any disease in the liver, what happen? There is elevated level of ammonia. What is the significance of urea cycle? It disposes the ammonia. If urea cycle is not happen, what happen? There is hyperammonemia. Understand? Arginase enzymes, which is a fifth enzyme, and what happen in these reactions? Arginase, it removal of ammonia in the form of urea. And if you see the molecular there is removal, and these urea become removed from the kidney and excrete out from the body, Okay, now we easily concept with both the things. You understand the urea cycle? It is partially mitochondrial, partially cytosolic. Why it is partially mitochondrial? Because there is compartmentalization. Compartmentalization is what? Some enzymes present in the mitochondria, some enzymes present in the cytosol. Okay, so in both the reaction, what happened? The CO2 and NH3 combine with each other in the form of enzyme carbonyl phosphate synthase with the help of enzyme NAG. Now regulation of this regulation. First regulation, NAG regulated allosterically, CPS first, means it is interdependent with each other. If NAG is not here, urea cycle did not proceed well. If NAG is here, their urea cycle proceed well. Okay, so this is the major regulation. Some other regulation given in the book you studied. Okay, now energetics. Energetics means, you understand, there are 4 ATPs here. 4 ATP. But here in this step from arginosuccinate, there is removal of one important biomolecule. Molecule as fumarate. Okay. And by this fumarate, it is forms a substrate for TCA cycle called oxaloacetate. And these oxaloacetate utilizes 1 NADPH. 1 NADPH means 2.5 ATP. So there is net consumption of ATPs for urea cycle is 1.5. 1.5. Okay, 1.5 is a net consumption because it is interconnected with each other. Now, why I am tell this bicycle? That both the cycle, urea cycle from one side and another TCA cycle proceed simultaneously, because these fumarate become converted into malate and these malate converted into oxaloacetate. It provides substrate for TCA. First thing, it is interconnected with each other, and now second thing is CO2. This CO2 is produced by TCA cycle. So it is gives the substrate to urea cycle, it takes the substrate from urea cycle. That's why it is called bicycle. Both the cycle proceed each other. Understand? So this is the main concept here, the disposal of ammonia by the urea cycle. I think you understand. Now we understand the disorders related with each other. Okay? हाँ, एडेनोसिन मोनोफॉस्फेट वो देख लेना तुम, 4 हुआ 10 होगा बाद में. Now we understand the disorder. Disorder is hyperammonemia. Ammonemia, you understand? In the blood, hyperammonemia first. This is measured by deficiency of carbonyl phosphate synthetase. This causes CPS. Okay, there is symptom is what? Elevated level of ammonia in the blood. Second one, hyperammonemia. Second, it is by OTC, ornithine transcarbamylase. Ornithine transcarbamylase. Ornithine transcarbamylase. Okay. It is called second, hyperammonemia second by ornithine transcarbamylase. Third one, citrullinemia. Citrullinemia by the enzyme defect. Which enzyme is defect here? Student tell. Arginosuccinate lyase. Sorry, arginosuccinate synthetase. Arginosuccinate synthetase. Fourth one, arginemia. Arginosuccinate lyase. Last one, which disorder? It is arginemia. Arginemia by arginase enzymes. Arginemia by arginase enzyme. And homocystinuria. And these arginemia. These are 5 disorders related with urea cycle. How can we classify it? If we identify citrullinemia, it is a substrate of urea cycle. If we identify arginine, it is a substrate of urea cycle. Okay. So majorly the major symptoms of this are what? High level of urea in the blood. Ammonia intoxication is primarily. And there is one, I tell you in the starting, there is HH syndrome. HHH syndrome related with the urea cycle. This is nothing, this is ammonemia. HH syndrome is hyperammonemia. Right here, hyperammonemia. Second is hyperorthinemia. Orthinemia. And homocystinuria. Both occur, these three of the condition both occur by defect of enzymes called OTC enzyme, orthonyl transcarbamylase enzyme, genetically defect. So, okay, if it is not genetically, there is gene defect, the OTC enzyme is not proceed well, they causes HH syndromes. Okay. Now we summarize what I taught you. That firstly, we understand the transamination reaction, that is formation of ammonia. That is firstly formation of ammonia by transamination and deamination reactions. Then storage form and transport form is glutamine. Then disposal of ammonia by urea cycle. Urea cycle is partially mitochondrial, partially cytosolic. How will you identify? If the enzyme is started from A, it is cytosolic. Okay. So there are CO2 plus. If you remember this, आपको वैसे ही याद हो जाएगा. याद करेंगे, 2 बार लिखेंगे, यूरिया साइकिल इजीली याद हो जाएगा. कैसा है? CO2 plus NH3, there is a formation of CPS enzyme first, which is forming carbonyl phosphate. Okay, and these carbonyl phosphate react with ornithine, it form citrulline, and this citrulline is further converted into which substrate? Arginosuccinate, and this arginosuccinate is again converted into argine, and this argine further by the presence of enzyme arginase, it produces ammonia. With combined with H2O, it produces ammonia, and these ammonia become excreted out from the body by kidney. So that means, what I mean, if the person is having acute kidney disease, ARF, acute renal failure, chronic renal failure, what happens? There is less excretion of urea from the body. That's why the level of urea increases. Okay, it's we call azotemia. There are 3 causes of hyperuremia: pre-renal, post-renal, and renal. You read all of this. I think time is over. I left the class. You are going for the practical and dissections also. Okay. So some of the case we discuss clinically in the next class. Thank you.
Okay. So today's topic is front of thigh and adductor canal. The skin and superficial fascia of the front of thigh, we will get the deep fascia. Okay, deep fascia of the front of thigh is known as fascia lata. Okay, deep fascia lata. Lata word is coming from latus, that is a Latin word, and that means extensive. Okay, so its extent is extensive, and it is a tough fibrous sheath that encloses the thigh like a sleeve. What are the attachments of the fascia lata? That is important. So superiorly it is attached to the inguinal ligament, iliac crest, gluteal fossa, pubis, pubic arch, and ischial spine. And through the okay. Okay, and through the gluteal fossa, the fascia lata is attached to sacrum, coccyx, and sacrotuberous ligament. This is the superior attachment. And inferiorly, it is attached to the front and sides of the knee, subcutaneous bony prominences, and capsule of the knee joint. These are the attachment of fascia lata. Now, what are the modifications of the fascia lata? that is also important. One is iliotibial tract. Iliotibial tract is a thickened band of fascia lata located on the lateral side of the thigh, also called maciate band. And width of this band is about 5 centimeter. And what are the attachments? Superiorly, this iliotibial tract splits into two layers, superficial and deep lamina. This superficial lamina, it is attached to the tubercle of the iliac crest here. Here will be the tubercle of the iliac crest. And deep lamina is attached to the capsule of the hip joint. It is deeply placed, and inferiorly it is attached to a smooth area on the anterior surface of the lateral condyle of tibia. Here, on the anterior surface of lateral condyle of tibia at the lower end, it is attaching. Now, muscular attachment, two muscles are inserting on the iliotibial tract. Superficial 3/4 of the gluteus maximus and tensor fossa lata. These two are inserting into the iliotibial tract. See, here is the tensor fossa lata, here is the gluteus maximus. Okay. Now, what is the functional significance of this iliotibial tract? It helps, it stabilizes the knee both in extension and in partial flexion, and that occurs in walking and running. It also supports the knee against the gravity. Iliotibial tract supports the knee against gravity when leaning forward and slightly flexed knee, and prevents the individual from falling forward. Okay. So, these two are main functions of iliotibial tract. Now, this is one clinical aspect, iliotibial tract syndrome. It occurs due to non-traumatic overuse injury of iliotibial tract. Mostly occurs in runners or cyclists, and it results in pain and tenderness on palpation of lateral aspect of the knee. Here will be the pain on the lateral aspect of the knee. Near its tibial attachment, at the lower end. Now, another is saphenous opening. Saphenous opening just in viva. Okay. Saphenous opening is a oval opening in the fossa lata, and it is located about 4 cm below and lateral to the pubic tubercle. Size is about 2.5 cm long, 2 cm broad, and long axis is directed downward and lateral. Margins, the opening has a sharp crescent shaped superficial inferolateral margin, also called the falciform margin, and a ill-defined deeper medial margin. Closure of the opening, the saphenous opening is closed by cribriform fossa. We have learned yesterday, cribriform fossa was covering the saphenous opening, and it is formed by modification of superficial fossa of the thigh. Now, what are the structures passing through saphenous opening? That is very frequently asked in viva. Okay. Also can come as a part of OSP question. So, great saphenous vein, superficial epigastric, superficial external pudendal vessels, and lymphatics from the superficial to deep inguinal nodes. So, these are the structures passing through the saphenous opening. Okay. See here, this is the saphenous opening in the deep fossa of the thigh, and this inferolateral margin is well defined, and this medial margin is ill defined. Okay, and the cribriform fossa has been removed to show the opening. Now, different fossal compartments of the thigh. The deep fossa or fossa lata encloses the content of the thigh like a sleeve, and 3 intermuscular septa extend from the deep fossa to the linea aspera of femur. You have learned linea aspera during femur. Okay, and it gives attachment to 3 septa: medial, lateral, and posterior intermuscular septa. And these 3 intermuscular septa divide the thigh into 3 compartments: anterior, posterior, and medial compartment. Anterior compartment of thigh, it lies between the medial and lateral intermuscular septum, and it contains the extensor muscles. Here, see, this is cross section through the thigh. Here is femur. This is on the posterior aspect. Here is the linea aspera. Here 3 muscular septum intermuscular septums are attaching posterior intermuscular septum, medial intermuscular septum and lateral intermuscular septum, and this is the fossa lata, green one. Okay, and outer aspect of this, here is the skin. So these intermuscular septums, this will divide the thigh into three compartments. Anterior compartment today we will discuss. Okay, so anterior compartment or extensor compartment, it lies between the medial and lateral intermuscular septum. Okay, contains the extensor muscles quadriceps femoris. In between the lateral and posterior intermuscular septum, here is posterior compartment, hamstring muscles are lying here. Okay, posterior compartment, and here is the medial compartment in between the medial intermuscular septum and the posterior intermuscular septum. So this is medial compartment, it contains the adductor group of muscles. Okay, nerve supply of three group of muscles are also different. For anterior compartment, femoral nerve; for the medial compartment, obturator nerve; and for the posterior compartment, tibial part of sciatic nerve. Okay, hamstring, supplying the hamstring muscles. So anterior compartment of thigh lies between the medial and lateral intermuscular septum, also called extensor compartment, and it contains the extensor muscles of the thigh. Contents are muscles. Muscles includes this: rectus femoris, three vasti, vastus medialis, vastus intermedius and vastus lateralis; sartorius muscle, articularis genu muscle and tensor fossa lata. Nerve lying in this compartment is femoral nerve. Artery is femoral artery, and the fossal space within the anterior compartment is femoral triangle. Femoral triangle has been discussed yesterday, and adductor canal. Today it will be discussed, adductor canal. So in this chapter, the muscles of anterior compartment thigh, it is described. See, these are the muscles. These four muscles together, rectus femoris, vastus lateralis, vastus medialis and vastus intermedius, these four muscles are together called quadriceps femoris. Okay, within the tendon of this quadriceps femoris, patella is developing. Patella is the largest sesamoid bone. This is and other muscles are articularis genu, sartorius and tensor fossa lata. Now we will discuss the origin, insertion, action and nerve supply of all these muscles. Okay, first you see sartorius. This is the sartorius muscle, longest muscle in our body. Okay, its origin is from the anterior. See carefully the pictures. Okay, you can, from the picture you can remember the origin, insertion. Okay, so origin of sartorius is from the anterior superior iliac spine and the upper half of notch below this anterior superior iliac spine, and insertion into the medial surface of the tibia in the upper part. Okay, origin of this rectus femoris. Rectus femoris has two heads of origin, one straight head and one reflected head. Straight head originates from anterior inferior iliac spine, and reflected head from the groove above the margin of the acetabulum. Okay, this is the origin. And insertion into the base of the patella here. Insertion into the base of the patella. And this ligamentum patelli attaching at the apex of the patella, this is a continuation of this quadriceps femoris. Okay. Now these are the three vasti muscles: vastus medialis, vastus intermedius and vastus lateralis. Okay, origin of them we will discuss individually. So quadriceps femoris, four muscles of the thigh, rectus femoris and three vasti form a group of muscles, and that act as an extension of the knee and inserts on the tibial tuberosity through the patellar ligament. And this group of muscle is called quadriceps femoris because four-headed muscle, that means quadriceps means four-headed muscle in Latin. And patella is the largest sesamoid bone in the body, develops in the tendon of quadriceps femoris. Nerve supply, all these quadriceps femoris muscles are supplied by femoral nerve. Okay, mainly posterior division of the femoral nerve. Okay, Action key extension of the knee joint, and it helps for rising from sitting or squatting position by extending the knee joint. So this is the main action of this quadriceps femoris. So this is how you can test the strength of the quadriceps femoris. Ask the patient to extend the knee against resistance. Resistance is given from anterior aspect, and patient is asked to extend the knee. So this is sartorius. Sartorius is the longest muscle in the body, and it is called the talus muscle. This is important for your MCQ. What is talus muscle? Okay, sartorius is the longest muscle and also known as talus muscle. Sartor means tailor in Latin, and it is used for palsy position by people for meal or prayer, as well as by tailors. And this position includes flexion of the hip, flexion of the knee, and abduction and lateral rotation of the thigh during movement of the lower limb during tailoring. And origin is from the anterior superior iliac spine here, and the upper half of notch below the spine, and direction of fibers are obliquely downward and medially across the thigh to reach the posterior aspect of medial condyle of the femur, and the tendon turns forward and reach the upper part of medial surface of shaft of tibia. Here it is inserted. Okay, upper part of medial surface of the tibia. Insertion. Inverted hockey stick sepet insertion. Okay, posterior to it, gracilis and semitendinosus is inserted. So insertion inserts on the upper part of medial surface of shaft of tibia in front of insertion of gracilis and semitendinosus, and sartorius is supplied by anterior division of femoral lump. Okay, only muscular supply from the anterior division. Action is, it's being very long, sartorius is a weak muscle, performs this action, flexion of the hip and knee joint, and abduction and lateral rotation of the thigh. These are the actions of sartorius. So this is origin, insertion, innervation and action, flexion of the hip and knee joints and lateral rotation of the thigh. Okay. So sartorius, it can be given in your OSPE, and related questions will be asked like origin, insertion, nerve supply, action. You have to write down for 5 marks. Okay, very important, very commonly given muscle in OSPE. Next is rectus femoris. Okay, all these muscles, large muscles, can be given in your OSPE. Okay, so rectus femoris is straight, fusiform bipinnate muscles. Rectus means straight in Latin. Where is the location? It lies in the middle of the front of thigh. Origin, it originates by two heads, straight head and reflected head. See here, these are the two heads are joining. Here is the straight head from the anterior inferior iliac spine, and here is the origin of reflected head, groove above the margin of acetabulum. Okay, so and from the capsule of the hip joint. Then the superficial fibers are bipinnate and deep fibers are parallel. Both the heads unite at an acute angle to form a fusiform belly, and in the lower part of the thigh it forms a flat tendon or aponeurosis here. And rectus femoris insert at the base of the patella. Here is the insertion of the rectus femoris. Innervation, it is supplied by posterior division of the femoral nerve. All the muscle included in quadriceps femoris supplied by posterior division of the femoral nerve. Okay. Action, it acts as a kicking muscle as it flexes the hip and extends the knee. Okay. So this is origin, insertion, innervation and action of the rectus femoris. It is a kicking muscle, bipinnate muscle. Okay, this is sometimes asked in your MCQs. Okay. Now, কি হলো আগে স্লাইডটা দেখো? Okay. So Okay, so these are some facts. Sartorius is the longest muscle of our body. It is a flat band of muscle fibers that crosses obliquely downward and medially, and all the muscles of anterior compartment of the thigh are crossed by this sartorius because it is passing obliquely. You have seen in the cadaver, and the rectus femoris is bipinnate muscle and that lie in the middle of the thigh, and it is overlapped by sartorius, iliacus, tensor fascia lata in the upper part, and rectus femoris is an antagonist of hamstring muscle. Hamstrings are flexors and rectus femoris is extensor, so they are antagonist. And rectus femoris strain, it occurs in football or soccer player due top jumping kicking. Okay, it involves partial or complete tear of the rectus femoris because this muscle crosses both the joints. It crosses both the hip joint and also the knee joint. So during forceful kicking in football or soccer player, it can tear. Next is vastus lateralis. Vastus lateralis or vastus externas, it is the largest vastus muscle. Origin is important. You can be asked to show the origin of this vastus muscle in the femur. Okay, during femur also it must have been discussed. So the origin of vastus lateralis is in a linear fashion and forms the following parts of from the following parts of the femur: upper part of intertrochanteric line, then anterior and inferior borders of the greater trochanter, lateral lip of gluteal tuberosity, upper half of the lateral lip of linea aspera. Now direction of fibers, the fibers at the origin are aponeurotic and further fibers originate from this. It's তোরা পিছনে কন্টিনিউয়াসলি কথা বলে যাচ্ছিস, শুনছিস কিছু? আচ্ছা, okay. So the fibers at the origins are aponeurotic, and further the fibers originate from this aponeurosis, and the fibers of vastus lateralis form a bulky muscle on the lateral side of middle of the thigh, and fibers run downward and medially to reach the patella. Where is the insertion? Vastus lateralis inserts on the lateral part of base and upper 1/3 of lateral border of the patella, and few fibers to the capsule of the knee joint, tibia and iliotibial tract. Innervation from posterior division of femoral nerve. Action is extension of the knee joint. So this is the line of origin of the vastus lateralis. See, from the upper part of intertrochanteric line, then anterior and inferior borders of greater trochanter, then lateral lip of gluteal tuberosity and upper half of lateral lip of linea aspera. This is the origin. Okay, an insertion into the base of the patella and into the upper 1/3 of the lateral border of the patella. There is the insertion of vastus lateralis. Here is the vastus lateralis. Okay, and origin of vastus medialis, you see, from the lower part of intertrochanteric line and then along the medial lip of linea aspera, extending up to upper 2/3 of the supracondylar line of the femur. Okay, and vastus intermedius, it originates from the upper 3/4 of the anterior and lateral surface of the shaft of the femur, and this articularis genu, this originates from few slips just below the vastus intermedius from the anterior surface of the lower part of the femur. This is the origin of articularis genu. Okay, and here is insertion of vastus medialis at the base of the patella and in the medial 1/3 of the base of the patella and upper 2/3 of the medial margin of the patella. Okay, this is insertion of vastus medialis. So it is largest vastus muscle, vastus lateralis, Here is origin, insertion, innervation and action of the vastus lateralis. Okay. So vastus medialis also we have discussed. Vastus medialis is also called vastus internus or teardrop muscle. It is a bulky muscle that covers the medial aspect of the femur, and the origin of vastus medialis is in a linear fashion from the following parts you have seen in the picture. Lower part of intertrochanteric line, spiral line, medial lip of linea aspera, upper 2/3 of the supracondylar line, and direction of fibers of vastus on the lower part of the medial surface of thigh just above the knee joint, and fibers run obliquely downward and lateral, inserting into the medial part of base of the patella, upper 2/3 of the medial border of patella and capsule of the knee joint. This is the insertion. By posterior division of femoral nerve, action, it helps in extension of the knee joint, prevention of lateral displacement of the patella, locking of the knee joint by medial rotation of femur during knee extension. Sartorius, that is supplied by anterior division of femoral nerve, whereas the three vasti and rectus femoris, articularis genu, all these are supplied by posterior division of the femoral nerve. Okay. You have learned during femoral nerve discussion from femoral triangle. Okay. So this is vastus medialis, origin, insertion, innervation and the action. Next is vastus intermedius. It is situated in the thigh under cover of rectus femoris. Reflect the rectus femoris muscle to visualize the vastus intermedius. Originates from 3/4 of the anterior and lateral surface of the shaft of femur. Direction of fibers of vastus intermedius run vertically downward to form a flat tendon in the lower part of the thigh. Insertion inserts on the base of the patella. Innervation supplied by posterior division of femoral nerve. Action is extension of knee joint. Okay, so this one is the origin of vastus intermedius. Insertion here, base of the patella. So this is origin, insertion, innervation and action of vastus intermedius. Okay. Okay. Next is articularis genu, or also known as subcrureus. Okay. Articularis genu is a small muscle that consists of 3 to 4 slits, and it lies deep to the vastus intermedius, considered as detached part of vastus intermedius, and it originates from the lower part of anterior surface of femur. Insertion inserts on the upper part of the synovial membrane of the knee joint. It is supplied by a small branch of nerve to the vastus medialis. Nerve supply is sometimes asked. Okay. It is supplied by a small branch of nerve to vastus medialis through posterior division of femoral nerve. Action key, it prevents the damage to the synovial membrane of the knee joint by pulling the synovial membrane upward during extension of the knee joint. So this is the action. Okay. Psoas major and pectineus was forming the floor of the femoral triangle. Yesterday you have seen. So we will not discuss this part. Okay, next we will go to the adductor canal. Okay, this is very, very important. Adductor canal. Okay, adductor canal, it is a intermuscular tunnel situated on the medial side of the middle 1/3 of the thigh. Here, this adductor canal is like this. This is the location. Okay, middle 1/3 of the thigh. Intermuscular tunnel situated on the medial side of middle 1/3 of the thigh. It is also called subsartorial canal or Hunter's canal. Subsartorial canal because adductor canal is covered by the sartorius muscle, and Hunter's canal because John Hunter performed surgeries for the treatment of popliteal aneurysm in this adductor canal. Okay. Length of this canal is about 15 centimeter in length. Okay. And adductor canal, it extends from the apex of the femoral triangle superiorly to the tendinous opening in the adductor magnus inferiorly. Okay, where it is entering into the adductor magnus and going to the popliteal fossa, posterior aspect of the knee joint, popliteal fossa, and becoming continuous as the popliteal artery. Shape of the canal, it is triangular on cross section. Okay, adductor canal. Boundaries are very important. You have to see the boundaries and content of the adductor canal in the cadaver. Okay. So the adductor canal has three boundaries or three walls. First is anterolateral wall, that is formed by vastus medialis. Posteromedial wall, it is formed by adductor longus above and adductor magnus below. These two are forming the posteromedial boundary. An anteromedial wall or roof, it is formed by strong fibrous membrane or subsartorial fossa, and that extends between anterolateral and posteromedial wall. Roof is covered by the sartorius muscle. Subsartorial plexus of nerves lies between the subsartorial fossa and sartorius. So, how roof is formed, that is very important. Okay. From adductor canal also OSP questions can come. Subsartorial plexus, which nerves are forming subsartorial plexus is also important. Okay. So roof has a strong fibrous membrane that is known as subsartorial fossa, and that extends between this anterolateral and posteromedial wall, and it is covered by the sartorius muscle and subsartorial plexus of nerve. Here is the fossa, subsartorial fossa. Here is sartorius muscle. In between the two lies the subsartorial plexus of nerve. This is anterolateral wall formed by vastus medialis. Here is the posteromedial wall formed by the adductor longus above, adductor magnus below. Okay. So this is the triangular cross section through the adductor canal. Okay, understood? So this is the origin, extent, then boundaries, and these are the contents. What are the contents? Femoral artery, femoral vein, saphenous nerve, nerve to vastus medialis, branches of the anterior and posterior divisions of obturator nerve, and descending genicular artery. These are the contents of the adductor canal. What is the clinical importance of this canal? This is very important. Ligation of femoral artery is done in the adductor canal for the treatment of popliteal artery aneurysm. Okay, very common aneurysm is this popliteal artery aneurysm. Okay, this is very important. This is very frequently asked in your OSP or Viva. Subsartorial plexus, nerve plexus, how it is formed? It is a nerve plexus that lies on the fibrous subsartorial fossa under the covering of the sartorius. It is formed by contribution from these nerves: medial cutaneous nerve of the thigh, saphenous nerve, anterior division of obturator nerve, and it supplies the overlying fossa lata and skin. Okay, so these are the nerves forming the subsartorial plexus of nerve. Now these are the contents of the adductor canal. You have to see this: femoral artery, femoral vein, saphenous nerve, nerve to vastus medialis, branches of the anterior and posterior division of obturator nerve, and descending genicular artery. This is the last branch of the femoral artery. Okay. See, this is the cross section through the adductor canal. This is vastus medialis forming anterolateral boundary, posteromedial boundary formed by adductor longus and magnus. This is sartorius forming the roof. Here are the subsartorial plexus of nerve, subsartorial fossa. All these three are forming the roof, okay. And these are the contents: femoral artery, femoral vein, saphenous nerve, nerve to vastus medialis. See, it is entering into the content of the vastus medialis, and these are the two divisions, anterior and posterior divisions of the obturator nerve, okay. So these are the contents of the adductor canal. All these contents you have to see, okay. Now there is crossing of structures within the canal. See, this green outline is the outline of the adductor canal. See, in the upper part, the artery most superficially lying is this saphenous nerve. Deep to it lying this artery, and deepmost is the vein, okay, femoral vein. In the lower part, see, this saphenous nerve is crossing the artery from lateral to medial aspect. Saphenous nerve is crossing the artery and the superficial aspect, and the vein is going from medial to lateral, okay. Vein is going from medial to lateral aspect of the artery in the lower part. So this crossing you have to note, okay. And this is descending genicular artery arising from femoral artery, last branch of the femoral artery, okay. And this a branch from this descending genicular artery is accompanying this saphenous nerve, that is known as saphenous artery, okay. And these are the branches of anterior and posterior division of obturator nerve, nerve to vastus medialis. These are also content of this adductor canal. Okay. So relations of femoral vessels and saphenous nerve: in the upper part, anterior to posterior is the saphenous nerve, femoral artery, and then femoral vein. And in the lower part of the adductor canal, from lateral to medial side will be the femoral vein, femoral artery, and saphenous nerve. Thus, the saphenous nerve crosses the femoral artery anteriorly from lateral to medial side. Okay. And femoral vein crosses the femoral artery posteriorly to lie on the lateral side in the lower part of the canal, okay, from medial to lateral side. And rotation, why this crossing occurs? Rotation of lower limb during embryonic development results in spiral course of the nerves and vessels in the lower limb. And clean the, we have to clean the fat and fossa and trace the femoral artery to locate the adductor hiatus, where the artery and vein is entering on the posterior aspect, entering into the popliteal fossa and becoming popliteal vessels, okay. Now descending genicular artery. This is the highest genicular artery. Last branch from femoral artery divides into two branches. Saphenous nerve pierces the subsartorial membrane, joins the subsartorial nerve plexus. And now we are discussing the contents individually. Okay. Nerve to vastus medialis, it lies lateral to the femoral artery in the upper part of the adductor canal. An anterior division of obturator nerve, it emerges at the lower border of the adductor longus, gives branches to the subsartorial plexus. And posterior division of obturator nerve, it runs on the anterior surface of adductor magnus and ends by supplying the knee joint. Okay, so these are the continuation of this content. So these are the boundaries. You have seen anterolateral vastus medialis, posteromedial adductor longus above, adductor magnus below, roof by the subsartorial fossa, sartorius muscle, subsartorial plexus of nerve. All these structures you have to see. Okay. Okay, and what will be the dissection line? You see, one horizontal incision you have to give at the junction of upper 1/3 and middle third of the thigh for adductor canal. Okay, and next horizontal incision will be at the junction of middle third and lower third of the thigh, and then vertical incision joining the midpoint of these two horizontal incisions. Next, we will reflect the skin, superficial fossa, then deep fossa, then we will reach the adductor canal. Okay, its roof and all these boundaries and contents we will see. Okay.